Welcome to the deep dive. Today we're tackling a really interesting topic, congenital adrenal hyperplasia, or CAH.
Mhm.
It's this group of genetic conditions, actually quite common, but, well, surprisingly complex. Big impact on health.
Absolutely. And our goal here, is to take these revision notes we have on CAH and really boil them down, give you the high yield stuff you need to know.
Yeah, clear understanding, hopefully without getting bogged down in all the details.
Exactly. High yield, get you confident.
And it's fascinating, right? You've got these genetic disorders where the body can struggle to make some key hormones.
While making way too much of others, like male hormones, the androgens.
Precisely. So you get this really diverse range of symptoms. It's like the whole hormonal system is, well, out of sync.
Completely. So we'll cover the definition, the causes, risk factors.
Pathophysiology, what else looks like it, epidemiology, how it presents clinically.
Investigations, management, and then the longer-term outlook, prognosis, and complications.
And we'll try to throw in some memory aids, maybe some examples to help it all stick.
Ready.
Let's do it. So first things first. What exactly is CAH, the definition?
Okay, so CAH is basically a collection of genetic disorders. Key thing, they're autosomal recessive.
Meaning you typically need a copy of the faulty gene from both parents.
Right. And these disorders affect the adrenal glands. The core issue is problems making cortisol.
Cortisol, that vital stress hormone.
Yeah, and often, as a result, the adrenals end up pumping out too many androgens, male sex hormones.
And the number one cause, the vast majority of cases, is a lack of a specific enzyme, 21-hydroxylase.
Over 90%, right. That's huge.
It really is. But important to remember, there are other much rarer enzyme issues that can cause CAH.
Like 17 alpha hydroxylase.
And 11 beta-hydroxylase, 3 beta-hydroxylase dehydrogenases, different spots where the production line can break down.
Okay, but let's focus on that big one, 21 hydroxylase deficiency, since it's so common.
Definitely. So when that enzyme isn't working right, you get the cortisol shortage and the androgen excess. And it's split into different types.
Correct. You have the classical forms, which are more severe. They can be either salt wasting.
It sounds serious.
It is. Or simple virilizing, meaning signs of male characteristics. And then there's a non-classical form.
Milder. Later onset.
Exactly. Tends to show up later, milder symptoms. And interestingly, the gene for 21 hydroxylase sits on chromosome 6, right in the HLA region.
The bit involved in immunity.
Yeah, the HLA histocompatibility complex. It's an interesting link, maybe something for future research.
Okay, so moving on to etiology. The underlying causes, it's all genetic mutations, right? Affecting those cortisol enzymes.
Primarily, yes. Genetic mutations are the root cause. And again, mutations in that CYP21A2 gene, the one for 21 hydroxylase, they're the main culprit.
Got it. And the mechanism is practically enzyme defect stops cortisol, maybe aldosterone too.
Aldosterone, yeah, the salt-regulating hormone.
And the building blocks, the precursors, they get shunted down the androgen pathway instead.
Precisely. The pathway gets diverted, leading to that excess androgen production.
So who's most at risk? What are the key risk factors we should think about?
Well, the biggest one, naturally, is family history, because it's genetic.
Makes sense. Autosomal recessive inheritance.
Right. And that also means consanguineous marriages between close relatives increase the risk, because there's a higher chance both parents carry the same faulty gene.
Okay. Any specific populations?
Yes, there's a higher prevalence noted in certain ethnic groups, people of Ashkenazi Jewish descent, Hispanic backgrounds, and also Mediterranean descent seem to have higher rates.
Right. So that's definitely something to keep in mind clinically. Could be a clue.
Definitely an aha
Moment.
potentially.
Yeah. Okay, let's dive a bit deeper into the biology, the pathophysiology. What's going wrong inside the body?
So fundamentally, you've got these defective enzymes. They just can't make cortisol and often aldosterone efficiently.
Right, the production line is blocked at that step.
Exactly. So the stuff before the block, the precursor hormones, they start to build up
And nowhere to go but.
down the androgen pathway. So which specific enzyme is faulty determines the exact pattern of hormone imbalance, but the common theme is cortisol deficiency and androgen excess.
And those excess androgens, they cause the clinical signs we see.
They do,
Yeah.
especially virilization in females developing male-like features. In baby girls, this can mean ambiguous genitalia at birth.
Okay. And you mentioned a feedback loop disruption.
Ah, yes, that's crucial. Normally, cortisol tells the brain, specifically the pituitary gland, to stop sending out ACTH.
ACTH being the signal to the adrenals to make cortisol.
Right, it's a negative feedback. Cortisol high, ACTH low. but in CAH, cortisol is low.
So the stop signal never comes.
Exactly. The brain keeps pumping out ACTH, trying to get the adrenals to work harder.
And that constant stimulation makes the adrenal glands bigger.
Yes, that's the hyperplasia part of congenital adrenal hyperplasia. The glands enlarge. Okay, let's unpack this feedback loop a little more simply.
Please.
Think of it like a thermostat. Cortisol is the room temperature. The pituitary is the thermostat controller. If the room's cold, low cortisol, the thermostat sends a signal, ACTH, to the furnace adrenals to turn on.
Okay.
But if the furnace is faulty, enzyme defect, and can't produce enough heat, cortisol, the thermostat keeps sending the on signal, high ACTH. The furnace runs constantly, maybe overheats in other ways, produces excess androgens, but the room never gets warm enough.
That's a great analogy. Really helps visualize it.
Yeah.
So when a doctor suspects CAH, what else needs to be on their radar? The differential diagnosis.
Good question. Several conditions can overlap. If you see ambiguous genitalia or virilization, you have to consider things like androgen insensitivity syndrome.
Where the body doesn't respond to androgens properly.
Correct. Also, 5-alpha reductase deficiency, which affects testosterone conversion, and just generally other disorders of sexual development.
Okay. And in older patients presenting with too many androgens.
Then you'd think about more common things like PCOS, polycystic ovary syndrome in women, or even the rare adrenal tumors producing androgens.
So the key is that CAH can pop up at different ages with different symptoms. Got to keep it in mind.
Absolutely. It's not just a newborn condition.
Right. So how common is it? Epidemiology time.
In the UK, the estimate is somewhere around 1 in 15,000 to 1 in 20,000 births. But as we said, it varies.
Depends on the type and ethnicity.
Exactly. Focusing on that main type, 21-hydroxylase deficiency, 21-OHD, that's over 90% of cases. The classic, more severe form.
Yeah.
Incidence is roughly 1 in 10,000 to 1 in 15,000 based on newborn screening data from places that do it.
Okay.
Specifically in Great Britain, the overall CAH estimate is about 1 in 18,000 births.
Affects boys and girls equally.
At birth, yes, balance ratio. But boys with the salt wasting type might show more severe symptoms early on because of the electrolyte issues.
Right, the salt wasting sounds quite dramatic.
It is. About 75% of classic 21-OHD cases are salt-losing. The other 25% are the non-salt-losing or simple virilizing classical form.
And the non-classical form.
That's more common overall, but often milder or asymptomatic. Worldwide, among women presenting with hyperandrogenism symptoms, the prevalence of non-classical CAH is estimated around 4.2%.
But higher in specific groups again.
Yes, much higher in groups like Ashkenazi Jews, reinforcing that ethnic link.
Okay. Let's shift to how it actually looks in patients, the clinical features.
Right. And the big theme here is variability. It really depends on the specific enzyme, how bad the defect is, and when it shows up.
So severe forms in newborns, what are the signs?
In girls, the most striking sign can be ambiguous genitalia at birth. We can grade this using the Prater scale, which we'll touch on.
Okay. And salt wasting symptoms.
Yes, in those with the salt wasting type. Things like poor feeding, vomiting, being lethargic, dehydration, kicking in usually in the first few weeks.
And the milder later onset forms.
You might see things appear in childhood or adolescence, like early pubic hair that's called adrenarche, rapid growth spurts.
Thinking.
Yeah, acne too. In girls, irregular periods, maybe signs of virilization like excess hair or a deeper voice.
And what about boys? How does it show up in them?
Well, at birth, in the classical simple virilizing form, their external genitalia often look normal, maybe some hyperpigmentation, a bit of skin darkening, due to the high ACTH.
So less obvious initially.
Can be. Later, they might present with precocious puberty, starting puberty really early, and that accelerated growth.
Let's look at classical simple virilizing CAH more closely.
Okay. So girls often diagnosed at birth because of the ambiguous genitalia. Boys may be picked up on screening or if there's a family history, if untreated.
Problems later.
Yes. Both sexes get signs of hyperandrogenism, precocious puberty, the rapid growth, but then early closure of growth plates.
Leading to shorter adult height.
Exactly. Potential fertility issues down the line, temporal balding in males, severe acne, hirsutism in females. Here's where it gets really interesting. The long-term impact of that untreated androgen excess can be quite significant.
Yeah, sounds like it. And the classical salt wasting form. You said that's particularly urgent.
Extremely. So infants have the hyperandrogenism signs plus that critical inability to hold on to salt.
So the symptoms are
Poor feeding, losing weight or failing to thrive, lots of vomiting, dehydration, low blood pressure.
electrolyte chaos.
Total chaos. Low sodium, hyponatremia, high potassium, hyperkalemia, metabolic acidosis. It can quickly spiral into a life-threatening adrenal crisis. Recognizing this early is vital.
Absolutely critical. Now, the non-classical form, how does that typically present?
Often there's a family history. Symptoms are milder, pop up later childhood, adolescence, even adulthood. Lichene, early pubic hair, maybe that fast growth followed by advanced bone age and slightly shorter final height.
And specifically in females.
They're born with normal genitalia, but later might develop sutism, maybe delayed periods or irregular cycles, sometimes fertility problems.
And males with non-classical.
Could be early beard growth, enlarged penis, or sometimes it's quite subtle, maybe just ending up a bit shorter than expected or having fertility issues discovered later.
And the severity links back to how much enzyme activity is left.
Precisely. It's a spectrum directly related to the degree of 21-hydroxylase function remaining.
You mentioned the Prater scale for ambiguous genitalia.
Yes, it's a scale from 1 to 5 that describes the degree of virilization in newborn females. Helps standardize the description.
Useful tool. And just to recap, boys with classic forms often look normal at birth, except maybe that mild hyperpigmentation.
Correct. And carriers, people with just one copy of the gene.
Usually fine, no symptoms.
Usually totally asymptomatic, no treatment needed.
Okay, so how do we actually diagnose CAH? What are the key investigations?
Right, diagnosis. It involves several things. First up, hormone testing. That's fundamental.
Measuring cortisol, aldosterone, androgens.
Exactly, and specifically serum 17-hydroxyprogesterone, or 17-OHP. This precursor hormone is usually sky high in classic 21-OHD.
Okay, 17-OHP high. That's a key marker.
Definitely. Memory tip. Think 17 is high GH in classic CAH. It might be less elevated in the non-classical form, though.
And for the rarer types.
You might measure other precursors, like serum 11-deoxycortisol, if you suspect 11-beta-hydroxylase deficiency.
Makes sense. What else beyond those initial blood hormones?
Genetic testing is really important, confirms the diagnosis, pins down the specific enzyme defect and the mutation, especially useful with a family history or if hormone results are borderline.
And imaging.
Imaging studies like ultrasound or sometimes MRI can check the adrenal glands, see if they're enlarged, hyperplastic. And crucially, in newborns with ambiguous genitalia, a pelvic ultrasound is needed to see the internal organs, like the uterus and ovaries, and check the kidneys, too.
What about screening newborns?
Newborn screening programs, where available, use that blood spot test taken soon after birth. They measure 17-OHP.
Sketch classic CAH early.
Exactly. Early detection, early treatment. Though, worth noting, universal screening isn't everywhere. There are debates about false positives and cost-effectiveness in some places like the UK.
Okay. Are there tests that push the adrenal glands to see how they respond?
Yes, dynamic testing. The rapid ACTH stimulation test is common. You give synthetic ACTH and see how much cortisol and 17-OHP the adrenals produce.
And in 21-OHD?
You get a poor cortisol response and a huge jump in 17-OHP. Very suggestive, especially for classic CAH.
Is there a gold standard test, particularly for non-classical?
The corticotropin stimulation test, which is basically the same principle, just maybe a longer protocol, is often considered the best test for diagnosing non-classical CAH, as it can pick up more subtle issues.
And in sick newborns, other blood tests?
Absolutely critical. You need other blood tests like electrolytes, immediately looking for low sodium, high potassium, blood gas for metabolic acidosis. These point towards adrenal insufficiency, especially salt wasting. Plus regular checks of kidney function and blood glucose.
Anything else in the workup?
Checking bone age with a wrist X-ray is often done in older children presenting with early puberty signs or fast growth. Advanced bone age is typical. And of course, in ambiguous genitalia cases, a karyotype is essential to confirm the baby's chromosomal sex, XX or XY.
Important caveat about preterm babies and screening.
Yes, screening results can be less reliable in premature infants. And for nailing down non-classical CAH, you often need that genetic analysis and the stimulation test.
Right. So once you have the diagnosis, what's the management plan?
Management focuses on two main things: replacing the hormones that are missing and stopping the body from making too many androgens.
So hormone replacement is key.
Hormone replacement therapy is the absolute cornerstone. This means giving glucocorticoids to replace cortisol.
Like hydrocortisone.
Hydrocortisone is often the choice in children because it's short-acting, more physiological, In adults, sometimes longer-acting ones like prednisolone or dexamethasone are used for convenience, maybe once daily dosing.
And if aldosterone is low?
Then you need a mineralocorticoid replacement, which is usually fludrocortisone, helps manage salt and potassium balance.
And the doses aren't standard.
Not at all. Highly individualized. Depends on the specific defect, the person's age, weight, growth, hormone levels. Needs careful adjustment.
So ongoing monitoring is vital.
Absolutely. Regular monitoring is non-negotiable. Checking hormone levels in blood or saliva, tracking growth carefully, watching for side effects. It's a constant balancing act.
What about surgery for ambiguous genitalia?
Surgical interventions like vaginoplasty or clitoroplasty for girls might be considered, but these are really complex decisions.
Need specialists.
Definitely. Experienced multidisciplinary teams involving endocrinologists, surgeons, psychologists, and crucially, discussion with the patient and family over time. Timing and necessity vary hugely, and removing the adrenal glands, adrenalectomy, that's extremely rare.
Because you'd need even more hormone replacement.
Precisely. Lifelong dependence on high doses. So very rarely done. And don't forget psychological support.
Crucial for any chronic condition.
Especially one affecting development and identity like CAH can. Essential for patients and families.
Okay, let's talk specifics for chronic management. Classic CAH first.
Right. So childhood, usually hydrocortisone, multiple doses a day to mimic natural rhythm. Adulthood, maybe switch to longer-acting glucocorticoids. Fludrocortisone if they need mineralocorticoid.
And salt for the salt losers.
Yes, infants with salt-losing CAH need extra sodium chloride, usually for the first year or so. Sometimes growth hormone therapy is considered later to help with final height.
What about precocious puberty?
If true central precocious puberty develops because the androgens weren't controlled well enough early on, that needs separate treatment, often with GnRH analogs.
And the stress dosing. That sounds really important.
Critical. Anyone with classic CAH needs to know how to increase their glucocorticoid dose during illness, injury, surgery, any major stress to prevent an adrenal crisis. Memory tip. Remember, stress needs more steroid.
Got it. How about managing non-classical CAH?
Often, if symptoms are mild or absent, no treatment is needed. If children show signs of androgen excess, like early pubic hair or fast growth, low-dose glucocorticoids might be used.
And adult women?
If they have symptoms like hirsutism or irregular periods, options include the combined contraceptive pill or anti-androgen drugs like spironolactone.
Do they need stress dosing?
Generally, no, unless they've been on long-term steroids that might have suppressed their own adrenal function, but usually not required for the underlying condition itself.
You touched on prenatal treatment earlier.
Yes, prenatal therapy. Giving dexamethasone to the pregnant mother if the fetus is known to be at high risk for classical CAH.
To reduce genital ambiguity in girls.
That's the aim. Suppress fetal androgens early on. But it's complex, carries risks, needs specialist centers, genetic confirmation, not routine.
And managing newborns with CAH. Any specific dangers?
Yes, the neonatal period is high risk, especially for salt losers. Risk of low blood volume, hypovolemia, severe electrolyte shifts, low blood sugar, hypoglycemia.
So close monitoring is key.
Absolutely essential. Vitals, electrolytes, glucose. Prompt treatment with IV fluids. Hormone replacement is crucial to prevent adrenal crisis.
And surgery details.
Again, surgical management for ambiguous genitalia is very individualized. Depends on severity, anatomy, family wishes performed by specialists, not always needed or wanted. And bilateral adrenalectomy remains extremely rare.
Okay, so wrapping up, what's the long-term picture? Prognosis and potential complications.
Well, the good news is that with proper lifelong management and good adherence to treatment, the prognosis can be quite favorable. People can live full lives.
But it requires commitment.
Absolutely. Lifelong treatment, regular monitoring are necessary. It's a chronic condition.
And what are the potential bumps in the road? Complications.
Several things to watch for. Adrenal crises remain a risk if replacement isn't adequate, especially during stress.
We mentioned short stature.
Yes, that can happen due to the condition itself or sometimes the treatment. Fertility issues can occur, more so in severe forms, or if control isn't optimal.
Cardiovascular risks.
There's an increased risk of things like obesity, insulin resistance, hypertension may be linked to the hormone imbalances or treatment. Hyperandrogenism in women is a factor too.
Well,
Central precocious puberty if diagnosis is delayed or control is poor. An increased rate of polycystic ovaries in females.
but fertility can sometimes be improved.
Yes, particularly in non-classical CAH, managing hormone levels, maybe with low-dose hydrocortisone before conception, can help. Females might face delivery challenges if there's significant anatomical change, sometimes needing C-section.
Side effects from the steroids.
Long-term glucocorticoid therapy has potential side effects, bone density issues, weight gain, etc. that need monitoring, and one specific one for males.
Ah, yes, the TARTs.
Testicular adrenal rest tumors. Benign growths in the testes related to high ACTH can cause problems with testicular function and fertility if they get large. So regular checks are important for males with CAH.
Okay, quite a list of potential issues to be aware of. So to summarize this whole deep dive,
I think the main takeaway is that CAH is this group of genetic conditions needing lifelong care. It's all about balancing hormones, replacing what's low, suppressing what's high.
and understanding the different types, how they present, the potential complications, that's absolutely key for good care and quality of life.
Definitely. It's complex, but manageable with the right approach.
Absolutely. And if you listening want to dig even deeper, definitely check out reliable medical resources and guidelines. Hopefully this deep dive gave you a solid foundation, whether for revision or just broadening your knowledge.
And for anyone prepping for exams like the MSRA, resources like passthemsra.com are fantastic. They cover conditions like CAH really well.
Yeah, great shout. And also check out freemsra.com for more free resources to help you study. Thanks for joining us for this exploration of congenital adrenal hyperplasia.